As the director of outpatient vascular neurology for the Geisinger Health System, I've had the primary role of educating and creating greater awareness regarding the short and long-term complications of stroke in our community. Among the myriad of complications we often encounter in the months following stroke include post-stroke cognitive impairment, or PSI. PSCI has been associated with a significant degree of comorbidity and loss of independence, but is often difficult to identify and appropriately intervene on in the early stages of stroke recovery. Doctors Uttarkar and Jones's work on implementing a screening process for PSCI in the outpatient setting highlights the need for developing objective and structured methodologies to identify and circumvent late complications of stroke. This quality improvement project began with a simple chart review of approximately 80 patients seen in their vascular neurology clinic. Baseline chart review revealed that only about 35% of patients had any documented discussions regarding cognitive impairment during their visits, and the majority of patients just weren't reporting any of these deficits. They then enrolled 30 patients who had recently suffered either ischemic or hemorrhagic strokes that were then evaluated and conducted cognitive screening using short-term MoCA testing, or SF-MoCA, and CLC-24 questionnaires. The CLC-24 questionnaire has been shown to be a useful tool in assessing cognitive impairment in post-stroke patients. However, in contrast to SF-MoCA, which is a more objective assessment of a patient's cognitive function, this is more a subjective evaluation regarding your ability to communicate, your ability to do simple and complex tasks, your ability to read, write, and does rely on patients' subjective perspectives on how they're doing after their stroke. In contrast, SF-MoCA is something that we have very specific parameters for as far as what they can and can't do, and it breaks down into a score that can qualify and identify things like cognitive impairment versus moderate severe cognitive impairment. The use of two screening tools allowed to further elucidate the limitations of unstructured screening for cognitive impairment, as results from the study showed no correlation between patients' subjective complaints, i.e. the CLC-24 questionnaire, and more objective testing with the SF-MoCA. To put this into further perspective, more than half the patients who underwent SF-MoCA testing in this study were found to have significant cognitive impairment. And this number was far greater than that reported subjectively by patients on their outpatient encounters. Vascular cognitive impairment is the second most common form of dementia nationwide, and it's a number that's going to continue to grow as our patient population continues to age. Inherent risk factors include things like hypertension, dyslipidemia, all of which have been shown to be associated with things like progressive subcortical white matter disease. That progressive subcortical white matter disease, in turn, has been associated with gradual cognitive decline in our stroke population, and we believe is a strong correlation with things like vascular cognitive impairment. Trials such as that conducted by Drs. Uttarkar and Jones highlight the value of objective screening tools in identifying insidious post-stroke complications, such as PSCI. More importantly, they emphasize the importance of early intervention and optimization of classic vascular risk factors to educate and improve quality of life in our patient populations. I hope that future studies like this continue to occur and continue to evolve to really allow us to better optimize our long-term patient care for this very key patient population.